We all know, being a neurosurgeon, the importance of cadaveric dissection, as every day we open the brain and we have found difficulty in many places. The cadaveric dissection was done in our undergraduate studies, but where also most of us have not done the brain dissection. Now when we are practicing neurosurgery, we should try to learn cadaver brain dissection, which can improve our surgical skill and surgical results. So here we have done a small experiment by doing the cadaveric Sylvian fissure dissection. We choose the Sylvian fissure because this is the highway to the brain, many part of the brain, skull, brain, base and other parts also. If we know how to open the Sylvian fissure, we can do many surgeries, and you can enjoy the video now.
Lift it a little bit, and under the high magnification you put a small incision into the arachnoid, and then once you put the anterior point, to the anterior Sylvian point, you just don't cut it more, just put a small nick into that. If you start getting a release of CSF, this is okay. Otherwise, put the seizure like this into that. Don't do anything and just open it. So you will see whether there is something coming below, some artery or vessel or some connecting vein or something. If it is nothing there, then you can keep on opening it.
So no need for any assistant to
nothing.
The other,
nothing. I am alone. No, retractor is only to hold later on, not now. You just wait here. Once you open this arachnoid, cut this. Now you can see there is a big sea of CSF is released here. Once it is released, just wait for here. Then you see which side is more wider Sylvian fissure. So you can keep on opening. If it is going here, the vein is going here, and it is open here, you can keep on dissecting like this. This is the way how you can do.
So that much high you have to go?
Then you keep as much as possible. You can. It depends on your pathology where you are going.
Okay.
So now you can see that I am not damaging anything even in cadaver. See, now if you have more high magnification, you can see there is a arachnoidal bands in between. Can you see that?
Yes.
You just look into them and then keep on cutting one by one. Very fine.
अगर सर ऐसे वेन आ जाए बीच में, you can cut that.
You have to see it. First dissect the arachnoid around that vein. Now you can see how beautifully it is opening. Okay, so now don't put any retraction. Do some very small. Keep on ask your assistant. Can you zoom it and see that there are arachnoidal fibers between temporal and parietal, frontal and temporal? Can you see that? कल वहाँ पे वो थे ना, वो डम स्पेक्युलर्स भी थे ना, वो कहाँ है? नहीं है क्या वहाँ पे? मैं बहुत सारे लाया था मैं क्या? उससे रिट्रैक्ट कर सकते हैं अपन हल्का सा. और ये देखो कितना वो दिख रहा है ना, कितने भयंकर एडिशंस दिख रहे हैं ना बीच में. These are arachnoidal adhesions. There is nothing you are going to damage. You just have to spread it. इधर देखो, ये इसको रिट्रैक्ट, इसको थोड़ा सा रिट्रैक्ट करोगे ना, ये देखो. You can see these arachnoidal adhesions. फिर इनको धीरे से इनको खोलना है और बैठना है. ये देखो खुला, ये देखो, है ना. और you can open the seizure also, and then you can see whether there is something important or not. Right? So these are the arachnoidal bands. Here again, you come down. Where you find the space, you can keep on cutting. Don't damage any vein. Go slowly. When the brain is angry red, fiery red, you can distract it and then do that. So this is the main important area of the medial side, and if you go down, you can see the pons and the midbrain, and then you can see the aqueduct here. Can you see aqueduct here? And this part is the third ventricle. And what is this? Endothalamic adhesion. This very small fiber connections are between two thalamus. And here like also in all over the corpus callosum there are fibers which are called connection fibers or commission fibers you can also. And here will be the, here is the point where you can find the posterior commission, right? And then this is the, this part is the colliculize. Can you see the superior and inferior? You can see both, right? Can you see this? This is the optic chiasma. This is the right optic nerve. This is the left optic nerve which has been cut here, and this is the chiasma. And what is this? This is tiny structure. Stalk. This is the stalk here, right? This was stalkectomy has been done, right? And which is this artery? Which is this artery? Which artery is this? Can you tell me? This is basilar, is bifurcating into the PCA right here, and this is giving the perforators here. You can see fine perforators giving to the this basilar was here. Like if we can see in the another, yeah, it is here. No, it's not here also. It was cut in between. So this is the midline. The spinal cord started, and here we have the basilar artery, which is here. You can see here. If you remove this optic pathways, this is here. Right. This is the basilar dividing into by giving bifurcation into two PCA. If you see this at the base of the brain, this is the ICA, which has become supracranial artery, supracranial ICA. So this is now becoming MCA. It is going into the swollen fissure. You can see it very well.
Yes,
and this is the A1. This is the A1 going here. If this brain was on the left side, this looks like left hemisphere. So this is the left A1, and this left A1 is going here, and it is becoming ACOM here. Can you see? It is becoming ACOM. This is left A2, and this is right A2, and the right one will be on the another hemisphere. So this is the ACOM, and here you can see the A2 artery, and then you can see the frontopolar artery. You can see this frontopolar artery, small frontopolar artery, and then it goes the callosal artery. हम ज़्यादा वरीड रहते हैं तो आर्टरीज की एनाटमी अगर हमें बताया ये जैसे सिल्वर फिशर अगर हम देखें तो AMC यहाँ जाएंगे. You know the Juha this very focused approach for MCA bifurcation. You can see here. Can you see it in the silver fisher here? This is the, what is this? You know?
Optic tract.
No.
Sorry, olfactory tract.
Yes. This is olfactory tract. Very beautifully coming here. And this is the MCA. And this is the MCA bifurcation. This is the frontal branch. This is the temporal branch. And this is the Sylvian cistern. Once you open a Sylvian cistern, you will have a flood of CSF. You will see that how much of CSF is here, and the brain will get relaxed, right? And then the CSF, the MCA stem vessels, MCA stem aneurysms are very rare. But although there are MCA stem aneurysms, I clipped 2 weeks ago one MCA stem aneurysm. Most commonly, we will have a bifurcation aneurysms. So this is the frontal branch going here, and then this is the temporal branch going here. Now we'll come to the medial side. You can see the callosal artery, callosomarginal artery, and these are the branches of the cingulate, pericallosal branches, cingulate going. Can you see this? Callosomarginal is, there are so many, they are called callosomarginal arteries, right? So like this you can say this is there are so many frontopolar branches. So here these branches comes into action when we have some olfactory groove meningioma. Olfactory groove meningioma get supply from the two ways. Like one is the ethmoidal arteries. आपने A1 ट्रेस करी, आप A1 ट्रेस करते हो. सबसे पहले आप A1 को क्लीन करना है आपको. And look around the A1 that you have completely denuded the A1 around that from all around, because in case of temporary clipping, you can put it. In case of rupture when you need it. But I rarely use temporary clipping. I don't use because I don't like temporary clipping. So, but it depends on experience. Previously I used to. Now you go to A1 and keep on tracing the A1 along with the ipsilateral optic nerve. This is the distance between the optic nerve and the ACOM artery is how much? Optic plasma is how much? Do you know that? What is the diameter of IC here? What is the diameter of IC here? What is the diameter of IC here? They are very important points. You must know that. And once it goes MCA, then how much the size diameter of the MCA is less than the ICA, and what is the size of the A1? Can you see? You see the A1 is almost 30% of the MCA. और ये ऑप्टिक नर्व जा रही है, तो यहाँ पे क्या होगा? ऑप्टिको कैरोटिड सिस्टम. So आप थोड़ा सा रिलैक्स करोगे until unless there is a very thick SH. Then put dissection and keep on putting the water. So it will relax. It will dissolve the blood, whatever it is there. So then once you see the membrane, thin membrane here, just put a bipolar. If you have sharp bipolar or blunt bipolar, just put a bipolar here. हल्के से डालोगे और इसको खोल दोगे bipolar. ये फट जाएगी फिर शांति से बैठ जाओ. Most common is the flow is here. If the right side is dominant, then where you expect the aneurysm is like this, because it is the aneurysm neck and aneurysm fundus will grow in the position where the actual blood flow should have flown, but it is diverted because of the turn of the artery. So then you will find the neck here. So you have to separate the small perforators here. This is the optic tract. We have already told this.
So what if we ligate the perforator along with the clip?
Ligation is not possible. You have to coagulate. You can coagulate. So these are the two ACs going. There is an aneurysm. So then you have to see whether this aneurysm neck is where. So with the blunt right angle dissector, right? With the blunt right angle dissector, you can dissect the neck around. This is here. You can dissect the neck here. Look for the neck here, for here. Dissect it here very slowly. It should not be sharp, otherwise you can rupture the dome of the aneurysm. So, but sometimes because the patient's position is like this, but actually the patient is in supine is like this. So the aneurysms will be this. You have to see it from above. Like most of these aneurysms, you have to reach it to the neck is from here. Like you can see that. Put the light on here. This is the place where the neck is actually. In most of the aneurysms, whether it is directing anteriorly, anterosuperiorly, anteroinferiorly, posteriorly, posterior-superiorly, the most of these aneurysms arise from here. This is the recurrent humor which is going to the anterior substance.
You have to go above this thing.
हाँ कभी वो तो डिपेंड करता है, ज़्यादातर A1 A2 जंक्शन पे आता है. मैंने फोटो दिखाई थी ना वो, तो वो एक मेरे पास अभी फोटो निकल नहीं रही है. I have operated one in the recurrent humor aneurysm, so that was coming here. और अभी 3 दिन पहले I operated one ACOM aneurysm, and he had the this thing recurrent humor artery is infarct. This is the position where the neck is, right? So now here most important thing is that from where if you can divide the ACOM, what happens? Can you divide this? If you put a clip here on both sides of the artery and you can divide it, what happens?
It will create deficits.
Nothing will happen.
But if one
Nothing
is
will happen if
one
it
is dominant,
until unless one is dominant. That you have to see first in CT angio or DSA.
Co-dominant
Otherwise,
we can reach.
if one is dominant, another is there. But if it is azygous, like from one it is filling, I will show you one patient. If it is from filling from one side and on CT angio or DSA, the other A1 is not visualized, not opacified, then you cannot.
Then you can't clip on the
Then you
both sides.
cannot clip on the both sides. But otherwise you can clip because sometimes in these ACOMs the neck is very friable. And the most important thing here is the perforators coming posteriorly to the hypothalamus. If patient is having SH and his sodium is 130 or less, you can say he has ACOM aneurysm. There is no other diagnosis.
वो आई थिंक क्या था You said if a patient is having
SH rising from there, ECOM, and I had just shared my one of the this is the uncus portion, uncus medial temporal lobe, right? This herniates and this blocks here the third nerve and does the pupillary dilatation, which we see here. So now if you have time, I can dissect the whole optic tract and everything, like all tracts. But we need a patience and time. If we, the way I am doing is not the good way, but just to show you in lack of time. Now I have entered the temporal horn now. Can you see that? I have entered the temporal horn. So
ये optic tract
Radiations आ रहे हैं.
radiation
आप कितने डिग्री पे रखते हो हेड को? दिस इज ऑन लेफ्ट साइड, राइट. सो जैसे आपने सिल्वर फिशर रिलैक्स किया ना, आप यहाँ पहुंच जाओगे सीधा, है ना. तो आपके असिस्टेंट को सिर्फ ये बोलना है कि यार इसको थोड़ा टेम्पल लोब को हटा के रखना है, बीच में नहीं आए, कॉटन लगा के लगा लो. नाउ यू विल गेट ICA एंड दिस इज द ऑप्टिक नर्व. यू कैन सी फुल स्ट्रक्चर हियर. This is the MCA branches going into the.
Yeah.
You can somebody cut it so I can.
when we do transition approach for VG blade.
Can you see? What is this? What is coming from here like this?
Circular sulcus.
Frontal horn, body of the ventricles. Can you see ventricle? What man you are talking? See? Wow. Can you see it?
Yes.
See this? This beautiful creature of the God. See now, this is posterior, this body of the lateral ventricle, and this is the posterior, and this is the occipital horn. Now we can connect it with the posteriorly here. Can you see it?
Yes.
Now see, this is the lateral ventricle. Okay. So the what I was talking about, the recurrent humor coming here through the this thing perforator substance, and this is the caudate nucleus here, medial to the internal capsule. First this is insula, then external capsule, then internal capsule.
Okay, but बाहर से from exterior to interior.
Right. So this is insula of which we are afraid of. So if you see the frontal horn and if you look into here, what is this elevations are? They are the caudate nucleus.
Frontal capsule is below the lateral ventricle,
Yes.
pushing the lateral ventricle.
Yes. So basically, if leave it just a minute, most of the basal ganglia bleed is actually here, inside the insula in here, and a little to the temporal horn comes down here like, and then you should go from the cortex. I would not suggest you go through the sulcus because you are going to damage more in the sulcus. This is the optic nerve in chiasma, and this is optic tract. Right. So then if you go, if you want me to dissect the radiation, I can dissect and show you beautifully. So this is beautifully seen here, the choroid plexus coming from the body of the ventricle to the temporal horn, and this is the hippocampus. You can see beautifully, and the infimbrida here. Now in epilepsy surgery, it depends on that how much is involved. You can dissect it, you can cut it, and you can feel it. If there is a more hard, you can remove it till there, because the optic radiations are not here. It is like you can cut with the bipolar from here, as I am cutting it with the spatula.
डेंटेड वायरस ये रहेगा ना, ये इसके नीचे.
अभी खोल के दिखा देंगे, इसको काटेंगे. When we remove it, you can see it. They change from body person to person. Yeah, but you can grossly see that. Don't go towards the ventricle, because you can, if there is no interventricular bleed, you will make it interventricular bleed. So just lateral to it and medial to insula. This brain is little bit mutilated, but still you can see. ग्रे मैटर अलग से दिख रहा है ना, ये वाइट मैटर दिख रहा है अलग से. The consistency and the color. Fibers. है ना? क्या बोलते हैं इसको? olfactory cortex का entorhinal है ना, यहाँ ही होती है ना, ये यहाँ से आ रहा है ना, ये देखो ये ऑप्टिक ट्रैक्ट आ रहा है, olfactory आ रहा है ना, ये इफ यू गो हियर, ये तो मुझे आउट ऑफ सिलेबस चीज करा रहे हो हैं?
नेक्स्ट टाइम
See this.
ऑर्गेनाइज करेंगे पहले.
See this. We don't have that much of light. We need an OT light. This is optic olfactory. You should have this action filling. We have done, and then this is the occipital lobe. They have to reach here.
Yeah.
So they will be fanning out here like this. Here. So if you want me to dissect this only, then I can dissect it at some other time.
So
Whenever
it's
you come
coming on
again.
the superior part of the temporal
Medial part.
medial part of the temporal horn.
Not the superior one. So this is how it is going like. Here the in front of the this thing optic radiations. What is this? Crura.
Crura, yeah.
So the optic radiation, also not optic radiation, but the corona radiata becomes the crust, and crus cerebrei comes into here and comes here like that, and then it becomes the midbrain, right? So this is how you can do. This is how you can dissect. Can you lift it so I can cut it? So okay, that is the deeper structure. First, we will talk about the insula. This is the thin arachnoid. You can see this is the ependymoma. You can say, right? So this is the. So this is the part from where we are afraid of. This is the insula. What is the meaning of insula in English? Literary meaning? Yes. Actually, island is called isla in Latin. So it is called insula in some Portuguese language or something. So this is the concentrated fiber of the this is the crust. This is lateral to the crust. This is the insula. This is crust coming here. Can you see medial to the optic radiations? There is a crust which the coronal radiatus part. Right, and then if you go a little bit superiorly, you can see that there is an insula. So this insula is again the connecting fibers. Like we have the frontal lobes, very few fibers which are coming in from all over it and concentrating it here. So the insula is here. Then there is an internal capsule. And then intercapsule makes the fibers more concentrated, like a bouquet. You can see the bouquet is above it is wide, then it comes down. The flower bouquet which I got it this morning. Same thing, right. So before that, I will like to describe this. Sometimes I can show you the U fibers which are this insula, not in the insula, but you can see the fibers here. I can dissect. No, just fistus. Wait. You can see the grey matter fibers are here. U fibers. These are called the U fibers in the sulcus, in the gyrus, right? So that you can do it. These are fibers like coming here. And if you go there, if you do the dissection, if you want me to remove the vessels.
यहाँ से कहाँ तक जाएगा?
Beautiful picture. Going here and this is here. Right. कोई ना पानी डाल देखो कितने सुंदर दिख रहा है.
This is the entorhinal cortex.
Yes. It is going here like in here.
Yeah.